Welcome to our channel viewers. So this video series will be about extra levator abdominoperineal section versus abdominoperineal section, that's ELAPE versus APR. This will be the outline of this whole series, that we will discuss the background, the relevant surgical anatomy will be discussed briefly. What are the options for perineal dissection, that is APR, ELAPE, intersphincteric and ischioanal resection. How to plan the preoperative basically management, and what are the surgical technique per se for APR and ELAPE, what is the relevant literature and how this is leading to the shifting in the paradigm, and what is the take home message for the students. The abdominoperineal section or excision, APR/APE, these are interchangeable terms, and Sir Ernest Mile gave this concept, defined this technique in 1908, and this has been the standard of care for decades. There has been some evolution in the management and technique of this basic technique given by Sir Ernest Mile back in 1908. And ELAPE, that is extra levator abdominoperineal section, is one variant. So friends, I have given the relevant literature reference here in this part of the video, and these are the milestone papers or the landmark historical papers, and I request the viewers to go through these papers. These are free to download paper on PubMed, and so that you understand the historical perspective of these procedures. So the fundamental principle or aim of all this technique, whether it is LAR, APR, ELAPE or ischioanal resection, is to achieve a locoregional control and achieve a negative circumferential margins, that is CRM should be negative. And as we understand that management is challenging because the surgeon is working in the narrow confices of the pelvis and with poor visibility, and if there is a treatment failure, that lead to a local recurrence, and it is one of the dreaded complications. So these are two historical diagrams. First is the original diagram of Sir Ernest Mile, who gave the concept of abdominoperineal section, and is entitled Final Stage in the Evolution of Radical Abdominoperineal Section. So in this diagram, Sir Ernest Mile gave the concept that the basically lower rectal cancers are spreading up to the skin. Later on, this was modified by Sir R.J. Heald, who gave the concept of total mesorectal excision, TME, and he said that the true field of spread of rectal cancer is supralevator compartment disease. There are only two indications for abdominoperineal excision, that is, in a case of lower rectal cancer, when the sphincter preservation is not possible, that is despite the neoadjuvant chemoradiotherapy. In the present era, we will not operate a patient of rectal cancer, especially T2 and above, without the NSCRT. So when the sphincter preservation is not possible, it is directly invading the sphincter, or in a case of anal squamous cell carcinoma, which has not been successfully treated with chemoradiation. So these are basically two indications for the abdominoperineal resection. So we will discuss briefly the surgical anatomy, which will be relevant to our APR and ELAPE part. So the peritoneum, in case of rectum, it is another structure which is partially intraperitoneal. The peritoneum covers anteriorly 2/3 part till the pouch of Douglas, or where it gets reflected, and only 1/3 part posteriorly. So it is partially intraperitoneal, partially retroperitoneal structure. A lower 1/3, there is no peritoneal covering and is enveloped in the endopelvic fascia. The lower 1/3, there is no peritoneal covering, and here is the most tricky part of the procedure. Anteriorly in males, the dental fascia separate it from a rectum from the prostate and seminal vesicle, and it is analogous to the rectovaginal fascia in females. Posteriorly, the Walder fascia connects rectum to the anterior sacrum at about the level of S4. So this concept of a tube within a funnel, you have to understand, that is the rectum and inner canal. It's considered as a tube within a funnel, and funnel is basically the sides of funnel are the two stems of levator, and the external stem is the anal sphincter part. So this funnel wide part is the levator ani, and the external stem, which is the narrow tube, is the external anal sphincter, and within this funnel is the this our rectum and the anal canal. This is a tube within the funnel. So when the surgeon has decided to do the perineal dissection, that is the APR, so we have two options. One is traditional oblique standard APR and another is ELAPE. So in the option A, the resection margin is coned in at the levators. So as we reach at the level of pelvic floor, we go towards the rectum. Before that, it is the all parallel dissection. As we approach the this pelvic floor, that is the levator and I form the pelvic floor. So be coned in as depicted in this diagram, and there is a potential of coning that we come too close, specifically if the tumor is at this location. So basically our aim should be that we take out the specimen without compromising the margin. The negative circumferential margin, resection margin, CRM is the ultimate aim. So the option B is extended or cylindrical APR or extra levator abdominoperineal excision. So as given in this diagram, line diagram, abdominal mobilization of mesorectum is stopped at the lateral margin of pelvic floor. So as we reach the pelvic floor, we dissect the pelvic floor along with the specimen. So there is a wide transactional levators performed, resulting in a cylinder of tissue around the tumor. It avoids the coning at the level of the pelvic floor. The main indication of ELAPE will be when the tumor is within a centimeter from dentate line and the lower rectal cancer with threatened CRM. So these will be the basic indication, and as depicted in this slide line diagram, one side is towards the left side is the conventional APR and other side is the ELAPE. So if we do conventional APR in this case, then there is high possibility that it will result in CRM. On the contrary, if we do ELAPE in this part, then the possibility of positive CRM is less. We have to remember this, that the tumor within a centimeter of dentate line, and when the circumferential resection margin are threatened, there is a role of ELAPE. So there is one variation of APR or ELAPE, that is ischioanal resection. So basically we incise the levator muscle at later insertion, and then we take out the whole pad of fat of the ischioanal fossa alongside fascia of the obturator internus muscle. Just remember, it can be part of many questions, and it result in the widest defect. For that we will require a mesh, some prosthesis closer, and that we will discuss in later part of this series. And the indication will be when the tumor is directly involving the perineal skin, ischioanal fat or levator muscle, or there is a perforation of formation of abscess and fissure tract, then we will require a excision of this whole pad of fat. So friends, from here onwards, that is preoperative planning, the different options, the surgical technique per se of the ELAPE and APR. We will carry forward the dissection in the next part of this series, that will be second part of the APR versus ELAPE.